I think we do encounter often. We are not a very high volume center, but we do understand that these fistulas are um, are very, very troublesome. They are not only troublesome to the patient, they are also very troublesome for us. Now, just very basics. Since I'm talking about urinary fistulas, the fistula is named, it's a tract, it's an epithelial tract which is connecting two epithelial organs or hollow structures. So depending upon which two organs it's connecting, you name it. So the urinary, since the urinary tract is before the genital tract, it comes first. So you have these various kind of fistulas. I'll try and finish well in time, even before. Now, please remember there are about a 1 lakh fistulas which develop in the world every year, which is quite a number. And since we have a lot of home deliveries or deliveries which are being done by DIs, unsupervised, we do encounter these fistulas quite often. The most common ones being vesicovaginal, which according to this particular study says they're about 87.5. Then we have vesicouterine, which constitute about 7.1. And then we have urethrovaginal fistulas, which are 5.4%. And very, very rarely, post-hysterectomy, we can have something like a ureterovaginal fistula or as well. Now, another Indian study which said that the maximum, the most important reason we all know for us still remains obstetric injuries. For us, it is obstructed labor. All of you are doing cases of obstructed labor day in and day out. And that is why, for how long do we leave a catheter if you have very frank signs of obstruction? So one thing I would like to really specify is, if your patient starts leaking, you have to inform the senior most person in your team. Please remember that. Because often we have missed and we have diagnosed fistula 2 to 3 days after she started to leak. So for us still, obstetric injuries, especially obstructed labor, remains an issue. Then of course we have surgical trauma being the next most common. I've never seen a genitourinary fistula due to tuberculosis. I think urologists see this more often. But we do come across fistulas secondary to cancer, and we do come across fistulas secondary to radiation. There are very uncommon causes as well. We were discussing those causes just maybe yesterday when we were looking at those pessaries where where a neglected pessary can lead to a fistula. I have never seen one. Now, I think, so the most important, so this is just some data. So the most important part which I would like to talk about is clinical evaluation. We all know that the commonest reason and the commonest symptom that these patients present with is continuous dribbling of urine, right? But sometimes whenever the fistula is very, very small, and especially if it's an iatrogenic injury, the patient may come with discharge. Recently, we were evaluating a patient, hysterectomy done somewhere else. The patient only complained of watery discharge. So it's very distressing for the surgeon. So a history is very, very important. And then it also depends upon the kind of fistula that you're dealing with. So vesicouterine fistulas might not present with a continuous kind of dribbling. So we are at present managing this patient who is having hematuria during menstruation. And then she doesn't dribble continuously. Her dribbling is only present when she, soon after menstruation or when she has periods. So history, I think, is very, very important. And then, of course, you have to take a detailed history about labor, where she delivered, who did the cesarean, and everything. Now, another important thing, Munaf, mera video please play kar dijiye, is before we go on to exactly describe examination, I would just like to show you a little video. This is a very recent video. Traumatic fistulas are very, very rare. In my lifetime, I've just seen one. It was a penetrating injury, and we did the surgery with Professor Sharma was on duty, and we did that.
सर्वाइकल लिप है ना?
We did that repair. Now, this is one fistula that I would really like you to see, because we've had this recently, and I would label it as a traumatic fistula. This patient delivered outside somewhere, and 3 days later, she came back to us saying that she was leaking. And दिखाइएगा.
इस तरफ का सर्वाइकल लिप है ना? दिस इज माय एंटीरियर फॉर्निक्स, ठीक है? और मैं इसके बीच में जा रही हूँ, है ना? दिस इज द प्लेस वेयर आई एम गोइंग बिटवीन द टू. ये देखो आ रहा है ना यूरिन.
थोड़ा सा ढीला कर वीडियो में. अरे वीडियो में आ रही है.
दिस या आई एम फीलिंग द डिफेक्ट हियर. दिस इज वेयर द डिफेक्ट इज बिटवीन.
दिख रहा
She's
है.
holding the cervical lips, just like this floral cervical lip, and the anterior vagina is all gone. So recently we've had 2 cases. A second one where the cervical tear repair was done outside. The patient started to leak, and she came back to us with a stitched cervix. It was seen by the residents on duty. She came with PPH. You guys examined her, but you missed the fistula. It was only after she started to leak, and then we evaluated her again. 2 days later, we realized that there was a fistula in place. So please remember, traumatic fistulas also, though, I mean, they were a rare entity for me, I think they are becoming a reality with kind of unchecked cesareans that are being done in our center. And this other patient, she was given guarantee by some dai ke normal kara dungi types. So 100% guarantee कि मैं normal करा दूंगी. So you see, it was a very bad cervical tear, and it extended. It has 2 similar cases. So by the time we evaluated them, we decided to catheterize them. We have catheterized both these patients, and now we're going to plan their repair subsequently. Now, examination of the fistula is most of the times very straightforward. The kind of fistulas that we see, most of the times, whenever we do a perspeculum, the fistula is right there. So you have to see the size of the fistula. You have to see the site, at least in the vagina, you can see that once you're doing a perspeculum. So where is the location? Some people grade it according to size. Anything less than 5 mm is a small fistula. Anything which is over 2.5 is a large fistula. So you have to, so examination for us, whenever we do, and of course you have to do the regular per vaginum examination. But the problem is with the small iatrogenic fistulas. I have dealt with 2 kinds of fistulas. We couldn't see them on a simple PS. The patient was leaking. We couldn't figure out कि वो कहाँ से आ रहा था. So in that case, I feel you are always reading about this particular test, which is the methylene blue test. We keep talking about it to you. We expect you to know it. But I think if you can see the fistula, then you don't have to really do it. But if you can't see it, it's so very small that you cannot figure out कि वो आ कहाँ से रहा है urine, then I feel it's a fairly good test. Because you put these 3 swabs in the bladder, you fill the bladder with methylene blue, and if it is staining the vagina, or I don't even put a swab for those 2 fistulas, we just did a PS and we could see the drop coming from that one corner. So we knew it was there somewhere. So if you cannot really see, then methylene blue is a fairly good test. Then I feel that, of course, we get all those routine tests done, but I feel the other important investigation in all these patients is a cystoscopy. Very, very relevant. So why are we doing this cystoscopy? We are doing this cystoscopy because we want to see how many fistulas, where they actually are, what is the size, and you can always take help of the urology team. Sometimes you may, before surgery, you can even get this ureteric opening catheterized. And the other important thing that you want to see is how far it is from the ureteric opening. So suppose this thing is very close here and you're doing a vaginal repair. You can take that opening in your stitch line. So you have to do a cystoscopy to see how many, where they are in the trigone, supratrigonal, where the location is, how big it is, and it's going to help you plan your surgery, and how close is this to the ureteric opening. So I'm sure all of you have seen a cystoscopy. We do it pretty often. And this is the fistula that we are going to treat. You can see the ureteric opening is somewhere here. It's not a very good picture. ये हमारे अपने phone में से किसी की है. And this is the fistula. We did this cystoscopy during her periods. So we could see the blood coming out through this very tiny hole. So she's a previous 3 cesarean. Right? So I think cystoscopy is, these are the two investigations I feel which are are most useful and which are most commonly used by us. I don't, in my in my experience, I've never used imaging, but people have described imaging. They have described images from simple cystourograms to CT urogram to MRI, but I don't think this is a uterus. You can see the small fistula. It's a vesicouterine fistula. But I don't think we ever have, at least I've never done any imaging, because most of the fistulas that we treated were only after evaluating them on by methylene blue test. And then another important thing that I would like to highlight is, more than imaging, I feel that whenever we do a cystoscopy, we should evaluate these patients under anesthesia. Because once I have also been stuck, there is this very little fistula. I can hardly see it. And when we do this, we plan a cystoscopy and a evaluation under anesthesia with methylene blue in the bladder. We put the methylene blue in the bladder, and we can see a very thin, very minute hole. It was a post-surgery fistula in the area of the vault. So what we did is we probed it with some, वो होते हैं ना जिससे हम लोग probes जो हैं वो हम लोग use करते हैं for recanalization. One of those probes, we probed it with that, and it went through. We did a cystoscopy with a probe in place. So the cystoscopy was beautiful. We could see it is a very small fistula, very far away from the ureteric orifice. So we decided to do a vaginal repair. But the problem is that the moment when we took her for the vaginal repair, we thought we'll put in a balloon and we'll pull the Foley's and it'll be there for us to repair. But जब हमने वो डाला, and when we tried to kind of pull it down, we realized कि वो तो आ ही नहीं रहा था because of fibrosis. Accessibility was so poor. So that day I learned that if you want to really do a good surgery, you need to really evaluate them well in anesthesia before you decide what approach you're going to use. Although it was a very small fistula, we had planned her for a vaginal, but we should have done an abdominal procedure. Because she did not stop leaking completely. Then she started having some amount of dribbling, which was there off and on. So I won't go into details of surgery. Most of the times we always opt and go in for, yes, conservative management is very, very important. So we can do a conservative management for a small fistula. And it is only deemed fit if the patient presents to you early. They say within 4 to 6 weeks. I feel in 4 weeks it might epithelialize. But if she's coming to you early, then it's okay. We often do that. We just catheterize and we leave her and we send her home. We put in a silicone catheter and then we review her every month. कि भाई सब ठीक चल रहा है. This one of our patients came to us today. So we will now operate on her after 3 months. And the reported success rate of conservative management is about 7 to 15%. So people have also used very minimally invasive procedures for dealing with fistulas. One is electrofulguration, where you have this, just like Madam was showing you a cystoscope. I had a video, but I don't think it's any point seeing the video. You have this thin needle. Now that thin needle, just like she had in her cystoscope, where she was using that needle to put in the bulking agent, that kind of an electrode helps you to dissect out the epithelial or de-epithelialize that fistulous tract. And then you can seal the tract either by something like fibrin, or you can even do PRP. So Shine, we can also do PRP if we ever plan. Shine is doing a lot of PRP. And if you suspect a uretrovaginal fistula where, in spite of putting methylene blue, you do not have any methylene blue coming on into your swabs, and you still find that the swabs are stained with urine, you can go in for stenting if the patient is coming to you very early. But for uretrovaginal fistulas, you have to go in for an abdominal surgery. So surgery, you have to really plan, because it's very, very important to decide when you're going to repair. For most of our cases, we never do a very quick repair. People have done a repair after maybe 2 months, but I have never done a repair, I think, before 2 months. It's 3 months we all give. But radiation fistulas, sometimes post radiotherapy, if you have a fistula, number one, please always biopsy it, because you should be very sure that the patient doesn't have a malignancy. So it's not a malignant edges. So you have to biopsy the edges. And number two, if you have a fistula, please try and manage it conservatively initially and leave it for at least 20 months. Or some people say at least 12 months. So radiation fistulas, we don't repair immediately. So we all know that radiation causes a lot of end arthritis, just like obstructed labor causes a lot of compression necrosis. Radiation fistulas are because of obliterative end arthritis and subsequent a lot more fibrosis. They are more difficult to repair, so you have to really plan them well. Then, of course, we talked about a very thorough pre-op evaluation, just like I talked about. Do a good evaluation under anesthesia. Do your cystoscopy. You should be very well aware of the site of the fistula. And once you walk into the OT, you should know what you're going to do. So you should have the procedure planned before you really decide on what you're going to do and how you're going to repair, because the first surgery is going to have the best outcome, right? So most of us do a vaginal repair. I think some of you PGs will come across us doing the small fistulas. The abdominal approach is meant for fistulas which are larger, around 4 centimeter, or the fistula is recurrent. It is a failed repair. That, like in my patient, where she is now not continuously dribbling, but she is dribbling off and on, we will plan a abdominal repair now, because I cannot pull it any further. And after that little repair, I'm sure it has become more fibrotic. Then any fistula which involves the urethra or requires ureteric reimplantation, these kind we usually refer. And any fistula which is associated with an RVF or is due to tuberculosis, you have to plan an abdominal repair. We sometimes also can plan both an abdomino-vaginal procedure. Then there are many grafts that are very, very important. I brought in a lot of videos, but I think you can see those videos online as well. So the most important take-home message that I would like to give is, and of course these are the complications of surgery, infection. Tell them that in spite of doing the best, they might have incontinence and some amount of sexual dysfunction. But the most important key message that I would like to convey to my residents is that please, whenever you are evaluating a patient, especially who is having a fistula, first of all, please listen to what she's saying. Like this patient was having leaking and you thought, "Arey, wo to hota hai delivery ke baad" types. Just don't neglect it. So just listen to what the patient is saying, right? And then please evaluate her thoroughly in the OT. Don't just do a hodgepodge evaluation anywhere else. Properly evaluate her in the OT, preferably under anesthesia. I feel the entire team should evaluate, do a cystoscopy, see if we can pull, because a small repair, we are putting in a Foley, pulling and doing a Latsko kind of a repair, that we have to do after we have completely evaluated her. After a complete evaluation, you have to plan her surgery, what procedure, what approach you will take, vaginal, abdominal, whatever, and then plan it only if you feel you are capable of doing it. Otherwise, you have to refer her to a higher center. Thank you so much.
Can I ask, add something? Can I have a mic, please? Thank you. Just a quick one about fistula repair. When you are doing secondary fistula repair, like after interval of fistula repair, most of the repairs are excellent repairs, and usually they are successful. But the reason patient keeps leaking is not because of the failure of the repair. What happens when patient has a fistula for a very long time? Because of the continuous leaking, the size of the bladder becomes very small. Because when the bladder is not distended, the size of the bladder from grapefruit size becomes like an egg, as I gave example. So that is the reason of leaking, not the actual fistula repair failing. But we forget about that because as surgeon we always worry that our repair is going to be failed. Actually, it's not failure of the fistula surgery. It is because of extreme overactive bladder. Because the truther capacity, bladder capacity has become very small. So it is a good practice after any fistula repair to start patient on anticholinergic or beta 3 agonist, so that the overactive bladder symptoms will get better. Yeah, no, it is small volume, small volume, because incontinence is mostly because of over